The bioethical dilemma I would like to discuss today is healthcare provider perspectives and experiences caring for suicidal clients in the healthcare setting. Suicide accounts for 800,000 individuals worldwide per year. Suicide occurs in people of all ages and backgrounds, causing a major impact on their families, communities, and healthcare providers. A study in Canada was conducted, and it is estimated that for each death by suicide, there are 25 to 30 suicide attempts, resulting in emergency department visits, direct hospitalization, and/or mental health facility admissions. Traditional principles of bioethics, namely autonomy and non-maleficence, have the potential to become confounding when applied to the everyday ethics of suicide care. The healthcare provider's duty to do no harm, non-maleficence, can contradict a suicidal patient's autonomy regarding end-of-life decision-making, leading to ethical dilemmas for them. The Nursing Now text defines non-maleficence as the requirement that healthcare providers do no harm to their clients intentionally or unintentionally. The principle of non-maleficence also requires that healthcare providers protect from harm those who cannot protect themselves. Autonomy is defined as the right of self-determination, independence, and freedom. It refers to the client's rights to make healthcare decisions for him or herself, even if the healthcare provider does not agree with those decisions. Some of these patients are involuntarily hospitalized because they are a danger to themselves and possibly others. This leads to taking the patient's right to refuse care, and if at any point during the hospitalization the patient would like to take their own life, it is the healthcare provider's duty to stop them. I believe that a patient should not be involuntarily committed to a mental health facility. If they are a danger to someone else, they should be stopped, and that could be by the law, so justice, by a bystander, by a healthcare provider, anybody that could stop a situation, and then they should pay for the consequences accordingly. But that does not mean commitment. I believe that there are other ways that we could help an individual, but not to admit them to a 72-hour grippy sock vacation involuntarily. If they're a danger to themselves, I believe that they should be allowed to carry out whatever decision they have made. And all of this is due to bodily autonomy. So the book even defines bodily autonomy as the client's right to make decisions for him or herself, even if the healthcare provider does not agree with those decisions. So I do not agree with somebody taking their own life, and I would not like to see somebody take their own life, but that person chose to do that. So why should we stop them by involuntarily committing them to a mental health facility? And I think also it makes it tricky for healthcare providers because of the oath that we take, which is the non-maleficence, to protect our patients at all cost and to do no harm. So yes, we could be preventing a patient from taking their own life, and which is do no harm, and they could live, but then we just took away their bodily autonomy to choose. And so I believe that when it comes to mental health, there's so much more to it, that it's not as black and white as like a diagnosis, like a medical diagnosis for a disease would be. I believe that there needs to be more research done into mental health to actually see the true signs and symptoms. I mean, the DSM updates all the time, and signs and symptoms for all of the diagnoses change. So I think that we do not have enough knowledge on mental health to be able to involuntarily commit somebody, even if they are a danger to themselves or someone else. And I also do not think that we have the right to stop somebody from making the choice to take their own life, for whatever reason it may be, but especially for mental health reasons. Okay. Thank you.